My name is Venu Menon, and I'm delighted to have the opportunity to speak at another STEMI conference, unfortunately again on virtual, but hopefully we'll get to meet each other in person soon. I've always been delighted to be a part of this meeting. And thank you, Ajit, as well as Tom, for this very kind invitation. I'm asked to speak about managing mechanical complications after ST elevation myocardial infarction today, and I will submit that this is one of the most challenging areas in the management of acute myocardial infarction today. Shown here in the slide are three common complications of mechanical complications. You can see on the top left, a papillary muscle head floating in the left atrium from a papillary muscle rupture. On the right, a ventricular septal rupture from a right coronary infarct between the non-infarcted RCA zone and the hyperkinetic LAD zone. And then in the bottom, a pseudoaneurysm in the inferior wall in the setting of a small myocardial infarction. The good thing about this complication is that the incidence of rupture has decreased. What I've highlighted here is that in the pre-reperfusion era, the risk of rupture was fairly high. Then, along with the coming of PCI, the rate of rupture has decreased significantly. But with fibrinolysis, you can see the rate of rupture really does not change. It decreases rupture because of patency of the infarct vessel, but as you delay fibrinolysis, the risk of reperfusing into an infarcted zone clearly heightens the risk of rupture. And so delayed thrombolysis is associated with rupture. This is important because in the recent COVID era, when we had delayed times of reperfusion, whether it be with PCI or with primary angioplasty or with fibrinolysis, we did see a significant increase in mechanical complications during the COVID epidemic. I would like to refer the audience to this wonderful review called Mechanical Complications of Acute Myocardial Infarction, a scientific statement that just came out a year ago because it summarizes many of the things I'm going to talk about today. I was privileged to be a co-author on this document, and I think it is a pretty concise overview of the current state of the science. Here are simple descriptions of four major complications, and today I'm going to focus mainly on management issues, and so I will not spend too much time in this audience of predominantly very experienced cardiologists talking about what each of these look like and what they represent. Instead, I will talk about management issues in specifically. So let me start by going through a general overview of what we believe the current management of mechanical complications entails. Clearly, once you suspect a mechanical complication, that should be confirmed on cardiac imaging immediately. And we believe that these complications can simply not be adequately cared for in routine cardiology centers, especially given how rare they are, how little surgical experience there is. We believe strongly that these patients should be referred to specialized centers. We then get two scenarios. The first scenario is when we have a hemodynamically unstable patient where there is really no time to wait and watch. We need to make therapeutic decisions right away. And in the second situation are those who come in with a mechanical complication but are relatively hemodynamically stable, in which there's a little more time to decide what is the right thing to do for this patient. Regardless of which category you fall in, the management of mechanical complications is a team sport. And I would say that being surrounded by a group of cardiologists and surgeons with expertise in percutaneous repair, obviously in cardiac surgery, with mechanical circulatory support expertise, and also with palliative care, because we can't always repair these defects, I think is really important to successful management of these cases. So that being said, let me talk about some of the lessons I have learned over the years in the management of mechanical complications. So the first thing I would say is make a diagnosis, because once these people come in with an acute myocardial infarction, I can't tell you how many times they come in with a small inferior MI, they have a nice systolic murmur of a ventricular septal rupture, and they go immediately to the cath lab because of ST elevation. Someone stents the right coronary, puts the patient on aspirin and ticagrelor, and then we discover the patient has a ventricular septal rupture. That kind of a situation should be avoided. Remember, ventricular septal rupture or any mechanical complication, while it may be delayed, can often be present on presentation. And so if you do suspect of the presence of a ventricular septal rupture, confirm the diagnosis first and don't expose the patient to dual antiplatelet treatment, because that becomes very challenging for the surgeon and for definitive repair. The second thing I would say is that among all these complications, mechanical mitral regurgitation due to papillary muscle rupture has many flavors. What do I mean by that? We pay very little attention to the anatomy of the papillary muscle because we can't really distinguish one from the other. But what I've highlighted on this slide is that the papillary muscle and the support to both the mitral valve leaflets can take many forms. So while you can have a single papillary head that supplies and supports both leaflets, you sometimes can have multiple heads, and you may be supplying only a small portion of the mitral valve leaflet. So when you have mechanical complications with mitral regurgitation, it may be a little flail of a mitral leaflet with significant MR, or it may be the complete papillary head being avulsed with complete loss of support and flooding of the lungs. And those patients often do not even come to the hospital. So all mitral regurgitation that's papillary muscle mediated is not necessarily the same. And you need to be able to distinguish that. A little bit of luck on the patient factor can certainly make different cases appear very different. And just to highlight, here is a nice case of a papillary muscle rupture. You can see in the bottom on the transgastric view, you can have complete avulsion of the papillary muscle head that is well shown. You have a lack of support to the posterior mitral leaflet, to the anterior posterior mitral leaflet, and a severe jet of anteromedially directed mitral regurgitation that causes pulmonary edema and warrants immediate intervention. The next lesson that I would like to bring about is that even great surgeons need healthy tissue to operate, and temporary support buys you time. So what do I mean by that? Although this is a surgical condition, sometimes the mechanical damage that you see is so great that even a great surgeon with great experience cannot go and absolutely repair these kinds of defects. So here you can see a complete dissection of the interventricular septum, a massive left to right shunt, severe bilateral pulmonary edema. Although a surgeon might take this person to the OR immediately, it is unlikely this patient will survive with surgery because there's no healthy tissue to operate onto. Such a patient should be put on mechanical support with using ECMO or impeller. We don't have too much time to talk about the details of which technique for which kind of mechanical complication, but you have to rest these people on a ventilator, make them better, and have a plan for primary repair. Or sometimes, like in this case, we knew we couldn't repair it. So we actually listed the patient for cardiac transplantation. He was only 40 years old and went straight away to a heart transplant in this setting. Or mechanical support devices allow you to do novel things. So here's a case of a large anteroapical myocardial infarction with someone who had a residual EF of 15%. There was a large rupture, which I haven't shown you here in the margins of the anterior infarction. You can see Q waves on the EKG. And in this case, we supported the patient with a 5.5 impeller put through the left axilla, decompressing the lungs. And in that setting, we go in a week or two later with with a HeartMate 3 using the infarct in the apex as our entry site, but having enough tissue to put the patient on a left ventricular assist device. So certainly something that you can only do at a very tertiary or quaternary center. The next complication I would say is the lesson I have learned is that the role of percutaneous options is growing, but very niche. So there are times when we go ahead and go with percutaneous techniques like trying to clip a small flail leaflet or trying to go across the interventricular septum and putting a closure device to decrease mitral regurgitation. I would say that those kinds of cases, while plenty of case reports are small, and in that setting, we do them only exclusively when we can't do surgery, our overall results for long-term benefit have not been fantastic. The last thing I want to say is that the great surgeons are your best friends. And so let me highlight a case. Here's a man who presented to a hospital more than 1,000 miles away from the Cleveland Clinic with a small circumflex infarction. He was 53 years old, had one transplanted kidney, and was otherwise well. The doctors there stented the obtuse marginal, and as you can see, his LV function is fairly good after the original infarct, along with the fact that he did have eccentric mitral regurgitation, likely due to a flail of the posterior mitral leaflet in the setting of the papillary muscle head infarct. The local doctors didn't do anything for it. He was hemodynamically stable, and they elected to watch him in the setting of an acute infarct with DAP exposure. He presented 3 months later with shortness of breath, and here you can see a very large pseudoaneurysm involving the posterior wall. The doctors in that institution, and this is a large tertiary institution, documented the large pseudoaneurysm, and obviously he has severe mitral regurgitation from that posterior wall, from the papillary muscle rupture too, and the anteromedially directed mitral regurgitation. Here's his cardiac MRI. You can see on his cardiac MRI a huge pseudoaneurysm that I am showing you. And these are the stacked images showing a discrete area of pseudoaneurysm in the lateral wall. And once again, here is a stacked group of images showing normal lateral wall and then suddenly a large defect. So what would you do for this patient? This patient is 53 years old. He was in a university hospital 1,000 miles away, and they said, we can't do anything for you. Can we do percutaneous therapy? They thought not. Can we do surgical therapy? They thought not. And they wanted to list this patient for a cardiac transplant. This patient was transferred by helicopter, by plane, more than 1,000 miles to our CICU. And here he comes to our unit. And we have a wonderful cardiothoracic surgeon, Michael Tong. He's one of our young, fantastic surgeons. And he took this patient to the operating room. And here you can see appearing through the mitral valve, the pseudoaneurysm, along with the scarred papillary muscle. We put stitches in the perimeter of the infarct zone. A double layer of pericardial patch was placed. And then we closed the pseudoaneurysm over the patch for hemostasis. And this is his post-operative echo. Preserved LV function. Obviously, in the setting of the infarct in the lateral wall, he replaced the mitral valve in this situation. And you can see this patient did extraordinarily well. He walked out of the hospital with relatively normal EF, no heart transplantation, no left ventricular assist device, telling you that in this situation, this is a surgical disease, and you really need great surgeons to help you with outstanding outcomes. So thank you for the opportunity to give this talk. This is the Cleveland Clinic. This is how we emergently bring most of our patients to our heart center. That's this curved building in the front. And I'm delighted to have an opportunity to speak here. And I hope many of you will have the opportunity to visit us here at the Cleveland Clinic so that I may return the favor and prove to be as wonderful a host as Ajit and Tom have been over the years. Thank you for your attention.